of surgery. We just came back from the American College of Surgeons. Most are here. Dr. Wade and the rest of the team are back tomorrow. So we had a great showing, and I want to thank our faculty, residents, and students who attended the American College of Surgeons and really were phenomenal ambassadors for the department. Katie and Jillian and Scott Scott is here. However, we had the inaugural American College of Surgeons Rural Surgery roundtable breakfast this past Monday, where Dr. Reeds, Dylan Wade, James Hazen, Katie, and Jillian really did a phenomenal work in partnership with the American College of Surgeons. We had about a 50 attendants discussing various aspects of surgical cancer care in rural population, and this will generate work. This is based on the grant that we have in partnership with the American College of Surgeons. Also, I want to congratulate Dr. Samia Agarwal and Dr. Emily Brown for a phenomenal job at the surgical jeopardy of ACS. Please give them a round of applause. Congratulations to Dr. Hazen on an outstanding presentation of the Owen Wangenstein presentation on Monday. And congratulations to Dylan Wade, who had an excellent presentation yesterday at ACS. So please give them a round of applause as well. Our reception was a big hit, and we had a great time. So I encourage everyone to start thinking about projects or any way we can help you be present and visible at the 2026 American College of Surgeons, which is going to be in Washington, D.C. Also, we have another announcement. Dr. Javi is on Zoom. Dr. Javi received the 2025 Contributed Faculty Service Teaching Award, which is another prestigious award for the medical school. So he's one of the few faculty who received it this year, and it's incredibly well deserved. And I have to say that Dr. Balters, Dr. Patel, and myself immediately recognized him as a potential candidate for the award. And what stood out that he has the ability to balance an incredibly busy practice and commitment and compassion to teach, which is very hard to do. So he has the secret sauce, and whoever wants to learn it from him, I think he is an individual who really has done a phenomenal job, not to take from anybody else. So please, let's give him a round of applause for a well-deserved award. And now we move to another star in our department, Dr. McCall, who serves as an assistant professor in the Department of Surgery and assistant director of the surgery clerkship for the last few months, and has done a fantastic job since her arrival nearly a year and few months ago. So Dr. McCall serves as a member of the trauma team here at CHI CMC Bergen campus. She joined our organization in October of 24, so congratulations on 1-year anniversary, Dr. McCall. She's a full-time faculty in the Department of Surgery. She completed her surgical critical care fellowship at Louisiana State University in New Orleans, pursued a general surgery residency at the University of Colorado, and received her MD degree from University of Kansas School of Medicine. She's also board certified in general surgery and surgical critical care. As we all know, one of the clear and emergent positive attributes of Dr. McCall is her passion for teaching. She's actively involved in teaching and clinical care. She's made several contributions through her publications and presentations in the past, including the University of Kansas Women in Medicine and Science, the American Medical Association, American College of Surgeons, the Association of Women Surgeons, University of Colorado Staff Association, just to name a few. And since her taking the reins and assistant director under the assistant directorship of the clerkship with Dr. Balter, she's done a phenomenal job with our sub-Is and M4 and putting together a wonderful curriculum moving forward. Today, Dr. McCall will talk to us about breaking the cycle from injury prevention to trauma survivorship. Thank you so much for your agreement today.
Talk about some imposter syndrome. I forget about all the stuff that's on my CV sometimes. So today I just want to talk about the importance of mostly injury prevention and what we do nationally, what we do here in Omaha and at Bergen, and then to introduce the idea of trauma survivorship and why after patients leave the hospital is just as important as what happens before they get to the hospital. Let's see. So conflict of interest, I'm a trauma surgeon and I feel really passionately about having less trauma happen. So seems a little contradictory, but it's something that's really near and dear to my heart. So today we're going to talk about injury prevention and trauma survivorship and what they are. We're going to identify some risk factors for trauma recidivism and how we can prevent those from happening and demonstrate the importance of a multidisciplinary approach to trauma care from prevention through post-hospital care. So just some fast facts. According to the CDC, unintentional injuries are the fourth leading cause of death in the United States. It's also the leading cause of death for those between the ages of 1 and 44. So this is a really big problem. And just looking at mechanism of injury, about 40% of those deaths are preventable. So we have a lot of work still to do. And here is just a graphic showing the top 10 leading causes of death per age group. And just to highlight here, homicide, suicide, and accidents are in every single category and are the leading cause of death in ages 1 through 44. So a large number of patients that we can prevent accidents and even homicide and suicide. So this is just looking at the preventable and accidental deaths based on whether they were intentional. So that's going to include homicide and suicide, or whether they were accidental. So based on those numbers, there are hundreds of thousands of patients that we could potentially keep from having accidents in the first place, and the long-lasting effects based on those injuries. So in another way, looking at the preventable injuries, in 2023, we estimate that the preventable injuries were about 223,000. Back in 1992, that number was 86,000. So 154% increase in the number of injuries. And this can be attributed to multiple factors. Medicine is getting better. People are living longer. So there are a lot more elderly patients. People are working longer. And so there are a lot of work-related injuries that people may have that would have retired. The death rate was 66 per 100,000 of these patients. So that's also a pretty significant increase. And in 2023, 62 million people came to the emergency department or to their PCP with an injury. And so that's a lot of people. And if we can prevent even a small number of those patients, it's going to help both our hospital system, the workforce, and patients as a whole. So this is just kind of some of that information in a little video, if I can get this to play. Maybe. No, it doesn't want to play. That's okay. Essentially what this video was showing, that a preventable death occurs about every 2 minutes. And so it's a pretty significant number. There are about 26 preventable deaths every single hour. So we can make a pretty big difference in patients from that perspective. This is also a significant cost. So if you look at the number in the top left, so the total cost of all injuries is about $1.3 billion to our hospital system. And that number continues to grow as the number of trauma patients continues to increase and the number of insured patients continues to decrease. So that can be a pretty significant burden to the hospital system. And if you think about trauma centers, most of them are going to be in urban areas where there are less resources and there are more patients who need more resources. And so in order for those hospitals to be able to keep the doors open and keep serving the communities that they're in, this is something that we need to pay a lot of attention to. Based on recent events, so there are a lot of hospitals that are going to have to close their doors. And so if there are ways that we can support both injury prevention as well as patients within the hospital, we can provide more care to a wider variety of patients. Looking at just motor vehicle crashes alone, that was about $500 billion And then work-related injuries are going to be about $176 billion. The work-related injuries are also important. These aren't just large corporations, that are paying workman's comp to all of their employees when they get injured on the job. This is also small businesses. And so you affect the workforce and a lot of businesses, within your community that may be affected by workforce injuries as well. There are a lot of injuries that also happen at home. So also about $500 billion worth of cost of patients who fall at home, and whether that's elderly patients who don't have support at home, who don't have support to help them stay out of a facility. I think there are a lot of patients that don't want to die in a nursing home. And so what resources can we provide those patients to keep them at home and keep them safe? And then there are a small percentage that are public injuries. So people, tripping on a sidewalk or falling into a pothole or, various things that kind of go back to city infrastructure that affect patients as well. So talking about injury prevention specifically, the NIH defines it as activities that can prevent, ameliorate, treat, and or reduce injury-related disability and death. And there's 3 big strategies that we use to do this. So first, we have to persuade people to alter their behavior. So with our first patient in M&M this morning, how can we change that person's behavior? This person who is a significant alcohol drinker who wants to go home and drink more and fall, and got lucky the first time with a very small injury, but came back, a few hours later with a much larger injury that's going to affect his life in a big way going forward. Also, how can we change individual behavior by changing laws? So seatbelt laws. So that's something that's really important. And another thing that's important here in Nebraska is helmet laws. So when you repeal helmet laws, how does that change the rates of injury or even death by patients who maybe otherwise wouldn't have had severe brain injuries or died due to motorcycle crashes? And then provide automatic protection. This really just means enforcing things in a more concrete way. Injury prevention, we also talk about primary, secondary, and tertiary prevention. So primary is going to be what we do to prevent the event from happening. So creating physical barriers between bike and car lanes, and speed limits, things to just try to prevent things from happening in the first place. Secondary prevention is designed to minimize the impact or severity of the injury if it does happen. That's our airbags, our seat belts, car safety. And tertiary prevention is focused more on preventing the consequences. And so providing rehabilitation to get patients integrated back into society in a more meaningful way. So injury prevention is still relatively new. So the National Safety Council first began collecting data back in 1913. But you can imagine in 1913, it was really hard to collect that data. It's not like there were computers where you could input this information and create a database. So it was really only the people who were contributing that were providing data. It was probably only in large cities. And so we were probably leaving out any rural areas. And they didn't really know what to do with that data. And so it took really until the 1960s when William Haddon Jr. Developed this Haddon matrix, which I'll show you here in a second, to better conceptualize what occurs during an injury event. And this gave us a little bit better framework to work in to identify actionable factors related to injuries. And then in 1966, the National Research Council published Accidental Death and Disability, the neglected disease of modern society. And so this is really when things started to take off in terms of focusing on injury prevention. Around that same time, there was a lot of legislation that was also implemented. There was highway safety, consumer product safety, and things that you may not consider injury prevention. So you imagine that you have all these factories that are, have people using heavy machinery, but there was no oversight. And so if there's no oversight, there's a lot of injuries that can happen based on workers not having enough education in how to use any of the machinery that they're using and different various things. In the 1970s, the CDC got involved and they began investigating injuries, but it really wasn't until the 80s that the Center for Injury Control was established. So really within the last 30, 40 years is when we've started focusing in a national way on injury prevention. And then in 1992, they created the National Center for Injury Prevention and Control. And it wasn't really until the 1990s that we started researching it. So the top table is what I was talking about earlier with the Haddon matrix. And so it looked at prevention, it looked at the event itself, and then it looked at post-event. And then here's some examples. So if we go back to motor vehicle crashes, you talk about prevention, so driving experience, defensive driving. Those are both things that we can provide to the community to improve their driving skills. And then brake condition. So having people get their cars serviced and making sure their brakes are working. Vehicle visibility, so with lights and providing more street lights on rural highways so that patients can see when cars are coming. And then also looking at the weather and the curves of the roads. And so you can imagine if there are a lot of blind spots on the road, that's going to increase the number of motor vehicle crashes that are going to happen. And so adjusting those things and changing speed limits and looking at whether or not weather or ice, you'll notice if you go over bridges, sometimes it'll say that the bridges are at a higher risk of having ice. And so all of those things have been implemented as a way to try to prevent injury. Then we move on to the event itself. And so seatbelt use is going to be the biggest thing. They also look at the speed at impact, vehicle size, vehicle safety features, and that goes back to looking at the engineering itself, and so making cars safer. And so the better impact rating and all of those things with cars, based on whether or not it's a convertible or a large SUV, and making sure that the cars themselves are being made in a safe way. Because you can imagine that a lot of the vehicle manufacturers aren't probably focused on our safety. They're focused on selling cars and what they look like. And so it takes some regulation to make sure that they're making them in a responsible way. And then post-event. So we look at ages, sex, frailty. You look at fuel tank integrity. So that's another thing, is if patients are getting in a crash and they're able to drive their car away, is that going to cause a problem where you're leaking fuel and then you start your car and your car explodes? I mean, crazy things happen. And so just making sure that there's a lot of education, post-event, 911 access, triage protocols, emergency medical services, all of those are really important. And then down at the bottom, this is just looking at the number of publications based on injury prevention. You can see that there really wasn't any research going on until largely the 1990s and 2000s. So a lot of work still to do. Here's some examples of some injury prevention programs, both nationally and here within the Omaha area. And so all of you are participating in injury prevention every single day, and you don't even realize it. Presumably you follow the speed limit when you drive here. Presumably you wear your seatbelt, but you also look at the PDMP when you're prescribing your opioids. So that is injury prevention, right? So if we're decreasing the amount of opioids that we're prescribing to patients, there's some evidence that shows that that's going to decrease the suicide rate. That's going to decrease the amount of opioid addiction. It's going to decrease the amount of patients that are injured while trying to go out and buy narcotics or other things. Water safety. And then the suicide crisis line, the National Safety Council, like we talked about, hospital-based violence, injury prevention, trying to break that cycle of violence. This is really focused on intimate partner violence, and how we can make sure that our patients have safe places to go once they leave the hospital. We have our SANE nurses here who evaluate every single patient, male or female, who comes into the emergency department who has had any sort of assault, to provide them both with exams for legal purposes if they need it, to get orders of protection or whatever they might need, but also provide them with resources and safe places to go if they need it, if they have nowhere else to go, but back home with the person who might have assaulted them in the first place. And then around Omaha, you might see the signs, keep kids alive, drive 25. So one of our folks in the trauma office, Alicia, who I'll talk a little bit more about later, she actually helps put these signs out around the community and in neighborhoods. U-turn also is something that we're involved with here as a trauma department. And this is a program for inner city kids to try to decrease gun violence and provide them with education and safety in a safe place to go after school so that they're not in dangerous situations, in after school programs. And then Steady is a program for the elderly to assess them for their fall risk. And so there are different ways that we can do that just based on physical exam in their PCP's office or at like programs in the community where they can go and have their fall risk assessed and make sure that there's resources, whether that's physical therapy as an outpatient, water therapy, Tai Chi, all kinds of things that can help decrease their fall risk. Another big portion of this, as I've alluded to a little bit, is advocacy. And so the American College of Surgeons Committee on Trauma is a big part of this. They provide advocacy at a national level in Washington, D.C., based on national laws. And they also provide a lot of resources to trauma centers to advocate locally, whether that's us advocating for seatbelt laws and helmet laws. But they also provide toolkits for how to do that, how to draft a letter to send to your representatives, what those letters should say. And here's just the website if anyone was interested in looking more into that and their position statements based on some national laws that exist. So here, what we're doing is we testified against the helmet repeal in person. So we actually had representation from our trauma center in person, talking about the helmet law. And then we were involved in city and statewide research after the repeal to see what the effects were after the helmet law was repealed. So what was the rate of injury? What was the rate of death? What was the rate of patients who never even made it to a hospital after the helmet law was repealed? Also, the Nebraska Nurses Association had a media campaign. They shared personal stories and trying to meet patients where they are, based on talking to them through the news and the media to make sure that everyone was aware that this was happening. Because if you're not turning on your TV, you may never have known that this helmet law was repealed and the effects of that within your community. There was also a nurse political reception where Alicia, one of our trauma coordinators, met with Nebraska senators to repeal concerns. So here is just some other examples of outreach. So this is a program, Teens in the Driver's Seat, that is within schools here in the area. And so it's a course where you can teach students about driving safety, and then they take a pre and post test. And you can see here, the students after taking this course had better knowledge of the importance of seatbelts and distracted driving, impaired driving. And almost none of them said that they didn't learn anything, which is, I think, big for high school students. And then here, just looking at the different outreach programs that we participate in here. So Scott, also in our trauma office, he does a lot of our outreach to EMS. And so that's between Crawford County, Papillion, Springfield, going pretty far out to talk with our EMS providers and both provide them with education, but also feedback. So if they send us patients and there's something that they could do better, we can provide that education and feedback to them to make sure that we take care of our patients better the next time that happens. We also do courses. So there's nurse trauma education. There's trauma grand rounds. We do resident orientation, we do reviews, we constantly are doing process improvement and quality improvement projects within our department. And that includes orthopedic surgery, neurosurgery, hospital medicine, and other various specialties where we all get together to discuss cases where there were complications, kind of like our own individual trauma M&M, except on a multi-specialty platform. And then other education that we provide, you all should be very thankful to Scott for scheduling your ATLS courses and providing asset courses to you. Without him, it would not happen. And so we're really appreciative for that. Alicia here, she also does a lot of Stop the Bleed courses. So going out to the community and teaching these Stop the Bleed courses to kind of teach the community about what to do if you have an exsanguinating injury and how you can help them make it to the hospital. Here's some examples of in-house education. And so there are 4 hours of continuing education for all the nursing units that take care of our trauma patients, which is going to be about every single floor in this hospital, which is a pretty big undertaking and a lot of nurses. There's an annual trauma boot camp. Like I said, the trauma grand rounds, where we collaborate with all of the regional Common Spirit trauma centers to provide education. And there are trauma symposiums. And then here, we teach asset courses, the trauma nursing courses, ATLS courses, and a wide variety of rural trauma courses and those kinds of things. So very busy. Like I said, we also do in-house case reviews and then debriefings with all of the staff. So anytime we have a full activation or a death in the trauma bay, we always get together just like a post code, and we review those cases. How does everyone think that that code went? How do we think that that activation went? What could we do better? What could the nursing staff, report back to us? What leadership do they think we could be better at? What things didn't work. So we've discovered a lot of things like the MTP phone not working when we're trying to do massive transfusion. Nurses not knowing how to set up the rapid transfuser, and so providing more education. And so it uncovers a lot of things so that we can be better next time. We also do a lot of trauma simulations. And so those involve the residents during the daytime and nighttime. So we'll go down to the trauma bay, do simulated trauma, run through it, make sure that all of the nursing staff participates, the residents participate, so that when the real thing happens, we're all prepared. And then we also provide both ATLS educator courses and instructor courses here in-house. And then in terms of quality improvement, like I said, all trauma activations get reviewed. We also look at over and under triage, because you can imagine over triage is not as big of a deal. That just means we responded a little bit more than we probably needed to, but under triage is a big deal. And so making sure that we're not missing patients that we might have been able to rescue prior to that, or missed activations. And all of those get reported back through EMS, through education. And so now to kind of turn to what happens once patients leave the hospital. So trauma survivorship is a growing area. And so this is defined as comprehensive care for trauma patients that includes commitment to returning them to society with the maximum physical and psychological function possible, consistent with their injuries. And so the thing that really made trauma survivorship important is looking at our TBI patients. And so this is a pretty large Danish study. They keep a lot better track of what happens to their patients when they come into the hospital and leave the hospital. And so what they found is that even with a mild TBI, there are long-term psychiatric illnesses and inability to work, and even major life changes like divorce that happen, even if you just have a concussion. They also looked at children. There's an increased incidence of patients that don't complete high school after having a TBI, or patients who have multiple TBIs in high school that never go on to complete their bachelor's degree. And so this isn't just an effect on a singular person. You can imagine that's also a very large effect on society as a whole. So we need to do better at providing supportive measures, including rehab to those with not just severe TBI, but providing resources to those with concussions, what to expect, how to maybe adjust your life at home or ask for help, because a lot of people don't like to ask for help, or they say, oh, I just had a concussion, I don't need anything. But they don't understand that there are a lot of downstream effects of even having a concussion. So we can do a better job of providing support and guidance, and even work accommodations based on post-discharge lives for these patients. Here's just another example. So this looked at, in the same study, the rates of work instability for the first 3 months after a TBI. And you can see based on your case percent and controls. So on your control group, it was all around 3.5% of patients who had work instability. But if you looked at any TBI or even a concussion, a skull fracture, the rates of work instability are much, much, much higher. And so any TBI, it's about 12.7% versus 3.4% of work instability at 3 months. And the big thing that I wanted to show is that persists. And so if you look at the work instability after 5 years, there's more work instability in your controls as well, but that number goes up to 19% for all comers to TBIs. So this is a pretty significant burden to patients and how they're going to make money and how they're going to stay at home and continue to, live the lives that they lived prior to their TBI. And then this is another graphic looking at the divorce rates. And so here, if you look at the adjusted incidence rate or incidence rate for 10,000. So if you look at patients who had no TBI, the incidence rate per 10,000 was about 1,600 patients that got divorced. If you look at any TBI, that number goes up to 2,700. And so there are a lot of reasons for this, whether it's, if you're a breadwinner and you have a TBI and you're unable to return to work, maybe the person who was staying at home with the children now has to return to work and they've never been in the workforce. And now you have financial strains, you have childcare constraints. Maybe the TBI is severe and that person can't stay home and take care of the children. So who's going to take care of your children when your partner has to go back to work? So there are various things that can put a strain on a marriage just based on having a TBI. So trauma survivorship, again, very, very new. It started really just with the idea of trauma survivorship in the 90s. And since then, we have had a little bit of growth, mostly within the past 5 years. I would say there's been a big push for trauma survivorship. But the ATS, or American Trauma Society, developed the Trauma Survivors Network in 2003. And I'll talk a little bit more about that, but that's really where we're getting most of our resources for our patients. We're currently a Trauma Survivor Network site, along with UNMC and Children's. And so we work with them to provide patients with resources. And here's just a graphic of the Trauma Survivor Network sites. And so these are not just level 1 trauma centers, but they can be level 2, level 3 pediatric centers, or even community hospitals that provide these resources. So you can imagine there are a lot of hospitals in the country, and only about 240 of them are Trauma Survivor Network sites. So a lot of work to do to get the word out about the resources that they offer. So, like I said, the Trauma Survivors Network was created by the American Trauma Society, and it really offers support, practical information, skill building resources in collaboration with trauma centers. And I will say this is probably one area where COVID helped. So they used to do just in hospital events where everything was in person, and you could see that that cost money. And so hospitals weren't really wanting to provide that unless there were grants involved, or hospitals who already had those resources available. But COVID said, hey, maybe we can do these on Zoom. And so it really expanded the amount of patients that we could reach by providing support groups, peer visitation, family support through Zoom meetings. And so I say this a lot, but I see trauma survivorship kind of like a cancer center, right? So you have this major life change. You get diagnosed with cancer. You get a lot of support in the hospital. You get your, support from your oncologist and your surgical oncologist. And then you get a lot of support afterwards. And there are a lot of support groups for patients who have been through cancer treatment. There are family support groups for how to help support those patients at home. And we need to provide that for our trauma patients too, because they're also going through major life changes. And so we're working now to identify patients who are going to be our champions in the hospital. So we've identified a couple of patients, one of which who is a TBI, another who is an amputee, who is going to come back to the hospital and offer their support to patients in the hospital who have gone through something similar. Because I think a lot of patients think that they're the only ones who are going through this. And so seeing people who have made it through the hospital and come out on the other side and reintegrated into society in a really meaningful way, I think can change their mindset and help them recover faster. So again, this is just another list of all of the Trauma Survivor Network sites. So there are about 220 adult trauma centers, and that varies from a level 1 to level 4, and then 19 trauma centers. And there's also actually one rehab center that is also part of the Trauma Survivors Network. So what can we do now? I think the big thing is advocating at both a local and national level. I think just having an idea of what laws are trying to be passed and how that's going to affect our patient populations. I know we're all busy, but that affects us directly on a local level within our community. So just paying attention to what's going on and making sure we're advocating for our patients. And then attempting to expand resources for injured patients, both in the hospital and post-discharge. We're trying to work with the psychiatry department on a lot of this, and based on like PTSD and providing support for patients in the hospital, and whether that be through trauma psychology or something else, trying to see how else we can better offer our patients support within the hospital. So here's just a picture of Scott and Alicia. Like I said, Scott does most of our outreach to EMS and coordinates all of our education. So you all should be very thankful to him. And Alicia, she does a lot with injury prevention and going out into the community. And she really works hard and will do anything to reach more of our patients, including dress up in a llama costume and do a race out here in Exarban. And to the trauma department as a whole. So all of us, I think, are passionate about taking better care of patients. And so I'm thankful to everyone for the support that they provide and the support for me wanting to push this stuff forward. And with that, I will take any questions.
Thank you so much, Dr. McCall. It's excellent. I really appreciate taking the time to highlight an important topic. And again, congrats on 1 year anniversary. It's a pleasure to have you with us. Questions for Dr. McCall?
Thank you for that talk and introducing us some ideas of what injury and injury prevention are. I'm curious, your observations in a year of how search and rescue, the helicopters worked in New Orleans, Tulane, where you were before, LSU were before, to how they work in Nebraska, and where you think our opportunities for growth are.
Yeah, so that's a great question, mostly because, you know, you think of Louisiana as having very little resources, but they actually had a very good centralized emergency services center. It was called LEARN. And so any patient who is out in the rural portions of Louisiana and needed to be transferred to a tertiary center, they would call someone at LEARN, which is the Louisiana Emergency Response Network. And they had all the information about what services each hospital provides, whether it's, you know, facial plastics or orthopedic surgery or neurosurgery. And they were able to get those patients to the closest hospital to them that had all of the resources that they needed. And so that helped kind of spread out patients throughout Louisiana, where they weren't just all being sent to New Orleans, which overloads the New Orleans hospitals, because LSU is the only level 1 trauma center within 2 to 3 hours and the only one within New Orleans itself. And so if all of these transfers were being sent to the level 1 trauma center, you know, we wouldn't have room. And so that's why they created this LEARN network that kind of looked at what patients needed and sent them to appropriate hospitals that weren't far from home, so that transport back home once they leave the hospital was easier, and that family could come see them and still be able to, you know, work and go to their jobs. So I think here in Nebraska, we get a lot of patients from far away, and they may stay in the hospital for a couple of days and then, you know, have to find their own ride back home. And some patients, if they're unhoused or don't have a car, that can be a really big burden, sending them far away. So I think, you know, just being mindful of that when patients get transferred, and trying to be better about who needs to be transferred and who might be able to be managed somewhere closer to home, if that answers your question.
Thank you both. Other questions for Dr. McCall? A question for you. Sorry, go ahead.
Thanks, Dr. McCall. I think it's so important to highlight, as you've done, the preventable nature of most, if not all, motor vehicle-related traumas. Not just for the occupants of vehicles, but I think also for cyclists, pedestrians as well. I think are a too often overlooked group motor vehicle trauma victims. Given that preventable nature of a lot of these injuries, I'm wondering if you've seen a shift either in your personal practice or perhaps in the scope of trauma surgery as a whole, I think the use of language to describe these patients, particularly in regards to the term motor vehicle crash rather than motor vehicle accident.
I love that question. So I don't know if the residents have heard me say it, but there's no such thing as an accident, right? So an accident by nature says that it's something that you can't predict or control. But these are all things that we found that we can make some sort of change and prevent from happening. So I was always taught to say crash, not accident for that reason. But yeah, that's a good distinction to make.
Other questions for Dr. McCall? I have a question for you about the mental health support for the trauma survivorship. What are the resources that we have here, and where can we grow?
Yeah, so here we're mostly using our psychiatry colleagues to consult patients who have really been identified as needing like PTSD resources. And so social work is doing a screener for all patients to see if they qualify or need more resources or qualify for a psychiatric consult based on that. But where I came from, both in New Orleans and in Colorado, we had trauma psychologists who were specifically trained in taking care of trauma patients and PTSD. And the benefit of that is that, one, that's their whole job. You know, the psychiatrists here have a lot of other patients who, need more intervention and more of their time. And so I think having someone around like a trauma psychologist can provide a lot of support for patients, both in the hospital and long-term. And so in New Orleans, they created a trauma survivor clinic. And so there were a couple of trauma psychologists who saw patients inpatient, and then they also had clinic days where they were able to follow the patients long-term outpatient and continue to provide support and resources that they need both in and after they left the hospital.
Thank you. Well, again, thanks so much for an excellent round. I appreciate you taking the time. I actually, Dr. Patel reminded me that credit goes to Dr. Emily Brown for the Cleveland Clinic course. It wasn't his idea, so he asked me to make that correction. So thanks, Dr. Brown, for.
Thanks to Dr. Walters and Rhonda Peavy for finding out about it and sending Sarah, Alex, and I.
Well, thanks to everyone. And what I failed to mention. Right, there was a comment or question? Good. Okay. What I failed to mention during the presentation of Dr. Bonner and Dr. Samuel, the concept of inclusion came up, and I didn't mention that if you go to the website for CHI and Clayton, you'll see that those are the core values. Not only compassion, you'll see inclusion and belonging. So both organizations expect us to uphold those values regardless of where we are or how we think about it. And actually our evaluation as we fill them now, those are questions that I'm asked to evaluate the individuals about it. And then my evaluation as a chair as well to ensure that people feel belonged and be part of the organization. So I wanted to bring that up. It didn't come up during the presentation. The last part was during ACS, Dr. Punja is still our chapter president of the Nebraska ACS chapter and has been very active during ACS. So did our medical students. We both have Brandon and Ted who attended representing the department, and then Raul Thusay, who is here or not, had a presentation as well. So we had a great showing. I'm going to pause here and hand it over to Dr. Castling. I know she has some announcements. You're okay. Thanks again, Dr. Michelle.
Let me just a second. Get these slides up here.